This is an EEG of a 27-year-old woman with a history of episodes of loss of time, and she recently had a convulsion. So as we look at this EEG, at first, of course, we want to check out the montage and see what we're looking at. And we have the left temporal chain on the top, right temporal chain underneath it, and then left and right parasagittal. It's a longitudinal bipolar or double banana montage. And as we look at this, we can see that the patient's eyes, it looks like she's got a little bit of eye movements here. They're closed, but she probably has a little bit of eye flutter. And her posterior dominant rhythm, it looks like it's about 10 hertz. So the frequency is normal and the amplitudes look symmetric. And the other things we want to look at with the background are the organization. So we look at the frequency amplitude gradient. In this case, it looks normal. So we see that normal progression from faster activity in the front of the head to the slower activity in the back of the head. Here you don't see the amplitude gradient quite as much just because her background amplitudes are a little low. She's probably a little drowsy here, and that's why. So the background is also reactive here. We can see this looks like her eyes are probably she's probably drowsy, and then there's a blink here, her eyes close, and she alerts, and we can see the background changing, so it's reactive. And here her eyes close again, and this is just drowsiness. We see the background attenuates there, and it looks like diffuse, low amplitude activity. Now, as we progress forward, we see her eyes are open, so we don't see the background activity. And she begins hyperventilation, and most EEG labs have the patients hyperventilate for between 3 to 5 minutes. And we look for any abnormalities, including this type of abnormality. Now, you can see this burst of activity definitely stands out from the background. And what is this? So in order to characterize this, we want to look at a few different features of it. First of all, we want to look at the morphology. So we see these are spike wave discharges. We see a spike wave, spike wave, spike wave. So that's what those are. They're spike wave discharges. We also want to mention the location. And these are diffuse or generalized. We see them in all of the leads. They're not just in one specific area, but we see them throughout all of the electrodes. They do look like they're higher amplitude in the anterior head regions, though. You can see these spikes are higher here in the front, and you don't see them quite as much in the back. And if we change the montage to a monopolar montage, we can also confirm that. So we can look at an average, and we can see that the amplitudes do look higher anteriorly, and in the back there's a little bit of a difference. I mean, this isn't quite as dramatic as on a double banana, so there might just be some contamination on the average montage. It's always good to look at a referential. Now I don't, oh here, we'll look at this CZ reference, which is probably going to show us that the amplitudes are pretty similar throughout because we're referring all these electrodes to the same electrode in the center of the head, CZ, and that one has high amplitude spikes, so all of these look like they have high amplitude spikes. It's really important to understand the subtraction effects with the montages. Okay, so if we go back to our double banana, now, so we've said these are spike wave discharges that are generalized with bifrontal predominance. The other thing we want to mention is the frequency. So there are 1, 2, 3, 4 of these in a second, so they're 4 hertz. If we look in the beginning here, are these truly generalized or not? It looks like possibly there might be something more on the right side before we see something on the left. So we see these spikes here on the right before we see spikes on the left, so these right frontal spikes. So there's a bit of a lead-in, we call it, a lead-in of spikes in the right hemisphere, in the right frontal area, before we see these generalized spike wave discharges. Now that's important because there are types of epilepsy, frontal lobe epilepsy with a mesial frontal source, where you can see this very rapid generalization, so rapid spread, and we call that a rapid bilateral synchrony. So this is a pattern that you can see in focal epilepsy, and you can also see this in the primary generalized epilepsies or genetic epilepsy, genetic generalized epilepsy syndromes. Okay, and as we keep going forward, we see more eye blinks. Now, she did have that burst during hyperventilation, and that is more characteristic of the generalized epilepsies. And here's another burst here. It's very paroxysmal. Again, it looks like there's maybe a right-sided lead in here. We see this higher amplitude right frontal spike and a phase reversal here in the right frontocentral region, followed by these generalized 4 Hz spike wave discharges lasting 3 seconds. And the tech noted that there were no clinical symptoms during those 3 seconds, which would maybe be a little hard to tell unless the patient was talking and stopped abruptly. Otherwise, we don't see any changes in the background. We don't see any abnormalities. There's no focal slowing or anything like that. Here's another burst. Similar here. I'm just turning down the gain, so looking again for that lead-in. So you can actually use this to see, to measure where do you see the very first change. This looks more bilateral, so we see these spikes bilaterally on the left and the right. And again, that looks to be about 4 Hz. Continuing on, she looks drowsy here. You can see the horizontal eye movements. And just very attenuated. She's drowsy. We're going to look for vertex waves to see if we see her becoming sleepier and see if we see any sleep spindles. Continues to have these horizontal eye movements. And it looks like there's a little fragment here of little spike waves on the right side. In the right, it looks like right temporal, right phase reversal here at T4. So little spike fragments, you can see those in generalized epilepsies. You see those in about 25% of generalized epilepsy EEGs. You will see focal spike fragments. Usually they're more frontal. So that isn't too out of the ordinary, except it's a little bit more posterior than what we usually see. Now here we're seeing some trains of vertex waves here. And we see superimposed on the sleep activity, it looks like there's a spike wave, and it's more notable over the right hemisphere again, right hemisphere predominant. And we see some posts and some sleep spindles, so now she's officially in stage N2 sleep, and there's a K complex with a spiky component. That's called dysrhormia. So the sleep components can sometimes have epileptiform activity riding on top of them. Now here's some more focal right hemispheric epileptiform activity. This looks like it's anterior temporal here, and it also has a frontocentral component on the right. So sleeping here, there's some more spikes riding on top of that K complex. And more vertex waves, and there's another burst of, it looks like the patient looks like maybe a bit of an arousal, and then she has some intermixed diffuse spikes there, and they look, as I said, they look diffuse. I don't really see any clear asymmetry there. Now she's waking up. We can see her eyes close, and then the nice posterior dominant rhythm coming out, and there's the end. So this is an abnormal EEG, and when you're writing your report, you want to, of course, say what the abnormalities are and what they mean. So I would describe this as an abnormal EEG due to the presence of frequent paroxysmal bursts of 4 hertz generalized spike wave discharges with bifrontal predominance. At times, a lead-in was seen with spikes in the right frontal region prior to the bursts. Additionally, focal spikes and spike waves were seen in the right anterior temporal region. I would also mention that the bursts of discharges, of generalized discharges, were seen during and after hyperventilation. And for the clinical significance, I would say these findings are consistent with either a genetic generalized epilepsy syndrome or a focal frontal lobe epilepsy with rapid bilateral synchrony, and clinical correlation is advised. The only way to really tell is to evaluate the seizure semiology, and that could help you distinguish between these 2 different epilepsy types.